Good afternoon, everyone. I'm Dr. Dimitris Tavares. I am the clinical advisor to Cancer Care Ontario for the PASA reporting project. On behalf of Cancer Care Ontario, the Partnership, and the Canadian Association of Pathologists, I would like to welcome everyone to today's educational session on the new CAP checklist on urinary bladder with Dr. John Srigley. Before I introduce John and we formally get underway, I would like to take care of a few housekeeping items. Firstly, today's presentation will be up to 90 minutes in length and will include 60 minutes of presentation time, followed by up to 30 minutes of question and answer period. Secondly, the session is being recorded and will be made available to all participants via email links once the recording becomes available. Thirdly, both the live presentation and the recorded presentations are eligible for CME credits upon the completion and submission of an evaluation form that is available electronically. The information for accessing the evaluation form was provided in the notice for the session previously distributed by email. Please note, CME certificates for each of the CAP checklist educational sessions will only be issued for 1 month from the presentation date. The recorded sessions will, however, remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline dates. Please note that everyone's line has been automatically muted for today's presentation. Due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you are having difficulties accessing the WebEx portion of this teleconference, please call the WebEx support line at 1-866-229-3239. I'll repeat that number, 1-866-229-3239. We encourage you to submit questions at any time during the presentation using the chat feature. For instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. During the question and answer portion of the presentation, in order to avoid question collisions, I will pose the submitted questions on your behalf as long as time permits and in the order in which they appear. In the chat window, please include the following information: your institution's name, name of the individual posing the question, and finally, your question. It is now my distinct pleasure to introduce Dr. John Srigley. John is head of the Pathology and Laboratory Medicine Program at Cancer Care Ontario and chair of the National Pathology Standards Committee for the National Staging Initiative at the Canadian Partnership Against Cancer. He is also presently the president of the Ontario Association of Pathologists. Dr. Srigley has championed the role of pathologists as diagnostic oncologists and is a strong advocate for population-level standardized synoptic pathology reporting. He has led the clinical implementation of discrete data field synoptic pathology reporting in the province of Ontario. Working with the National Pathology Standards Committee and the Canadian Association of Pathologists, Professor Srigley was a key leader in securing formal endorsement of the College of American Pathology Cancer Checklists as pan-Canadian content standards for cancer pathology reporting. He has also given presentations to groups such as the North American Association of Central Cancer Registries and provided advice to the Structured Cancer Pathology Reporting Project in Australia. Dr. John Srigley represents Cancer Care Ontario and CPAC on the Cancer Committee of the College of American Pathologists and is currently the president of the OAP and International Society of Urological Pathologists. Dr. Srigley is a graduate of the Faculty of Medicine at the University of Toronto. Following oncologic pathology training at the University of Toronto and MD Anderson Cancer Center in Houston, John was the Director of Surgical Pathology at Sunnybrook Health Sciences Center and the Chief of Laboratory Medicine at the Credit Valley Hospital. Currently, he is a consultant pathologist at Credit Valley Hospital and professor in the Department of Pathology and Molecular Medicine at McMaster University. Professor Srigley is an international consultant and educator in the fields of oncologic and urologic pathology and has contributed extensively to the literature. He is an author of 2 recent textbooks on the pathology of prostate cancer and has contributed to the 2004 WHO Blue Book on Pathology and Genetics of Tumors of the Urinary System and Male Genital Organs. His research interests include clinical, pathological, and translational studies of urological cancer and population-level quality initiatives in the field of cancer pathology. So I now hand you over to John.
Thank you very much, Timo, for that very kind words of introduction. What I'd like to do today is focus. This is the 7th in our current series of CAP checklist updates and presentations for the Pan-Canadian group. Today I'd like to focus on the checklist that relates to renal cell carcinoma. And in this particular checklist, which is shown on the current screen, the actual screenshot from the copy you can get on the web, either in PDF or Word format, is shown on the left-hand side. And this has been linked, of course, with the current cancer staging manual, which is the 7th edition AJCC manual, which is shown on the right-hand side. I wanted to emphasize with this particular slide that the group that we have involved in the checklist at the college includes a multidisciplinary group of pathologists and other clinicians, as you can see with the list of the authors. And this was set up a few years ago across all the subspecialty sites for the CAP checklist to provide broader input into the process and to have appropriate multidisciplinary representation. And I should say, on a go-forward basis, through CPAC and the National Staging Initiative, we're going to be setting up Canadian panels, one of whom will be a representative on each of these College of American Pathology panels as well. So we'll have pan-Canadian input on these particular documents. Now, what I'd like to do today with respect to our objectives, I'm going to be reviewing the new 2011 CAP checklist for renal cell carcinoma. I'm going to discuss a little bit about the gross handling of kidney resection specimens for renal tumors. I'm going to present the current classification and grading systems for renal cell carcinoma. And of course, I want to review the 7th edition TNM classification published in 2009 that relates to kidney cancer. So those are the objectives for the day. I want to really give some acknowledgement to my colleague and very good friend David Grignon, who's at Indiana University, an expatriate Canadian. David has lent me some slides, especially in the staging area. He has some very nice slides of the current staging system, which I borrowed for him so that I could show you some of the very nice illustrations of some of the staging issues that we have to deal with. Now, in terms of kidney cancer in Canada, it's a relatively common type of cancer that we see. About 4,800 new cases per year with a sort of a 3-to-2 ratio of male to females in terms of new cases. And kidney cancer is responsible for about 1,650 deaths. And this is information that was taken off the Canadian Cancer Society website as of a couple of days ago. So roughly about 5,000 cases across the country. So it's a relatively common specimen that we're going to be seeing. Now I'd like to show you the very important page that's on the current checklist. If you download the checklist off the CAP website now, you're getting the 2011 versions. And this is the first time where the college has gone through a very serious versioning exercise. You can see there's a version code on there, and there's also a summary of changes. So this was in part due to the pressure and the influence that the Canadian group, both through Cancer Care Ontario and CPAC, was putting on CAP to make sure that their documents were properly versioned so that we can keep track of the changes both in the written copies that you see here and also the electronic checklists that have been distributed as well. So this is a very important sort of step in terms of making sure that we can update these in a very orderly fashion and we know which version we're dealing with all the time. And you can see as well that the only significant change on this particular checklist was the fact that the regional lymph node status was changed, and this was actually through the Cancer Care Ontario and CPAC with the recommendation from the group at UHN that we have a different way of approaching the lymph nodes across all the checklists that relate to resection specimens. So This now includes a checkbox for no nodes submitted or found, which is important because if you get a resection specimen with no lymph nodes, you don't want to be forced to say 0/0. So in that case, there is this checkbox now for no nodes submitted or found, which I think is an important enhancement of the checklist. And as I said, this is across all checklists that relate to cancer resection specimens. So this is a little bit of Canadian input. Now, just a word about the biopsy. The biopsy checklist is an optional checklist, and the biopsy checklist, of course, includes procedure, laterality, then includes the classification system, grading system, presence of sarcomatoid change, etc. So there's a number of elements there, but it's all entirely optional. So I'm not going to be concentrating at all on biopsy. I will say a few words, however, that in some centers, there is a move towards a more conservative approach to small renal tumors where one might do local ablative therapy with radiofrequency ablation or other types of treatment like that, or in cases of situations where they have a small renal tumor where they want to have an active surveillance protocol, for instance, in a patient that has a single kidney or has impaired renal function, or as part of clinical trials. So there are groups that are doing core biopsies in these particular settings, and they're usually 18-gauge core biopsies that are directed by CT or MRI. And the literature tells us that in about 3/4 of the cases, one can make a diagnosis, and a fairly reliable diagnosis, sometimes with the help of immunohistochemistry. So in about 1/4 cases, one can't make a diagnosis, and those are issues where you have necrosis or reactive changes, fibrosis, and chronic inflammation with not enough lesional tissue or no lesional tissue at all, or in situations where you have problematic tumors as well. So there's one caution, I guess, and certainly the oncocytic tumors, so the issue of oncocytoma versus sort of an eosinophilic chromophore renal cell carcinoma sometimes comes up in a differential diagnosis, and in a needle biopsy, sometimes the sampling may be a problem in that regard, and you could use terminology such as renal oncocytic neoplasm, see comment, if both of those conditions are in the differential diagnosis. So that's really all I wanted to say about the biopsy situation. So let's move on now to the cancer resection types of specimens, the nephrectomy, both partial nephrectomy and radical nephrectomy. And you can see the check boxes there for procedure and laterality, of course, are mandatory. They're not optional. And what I'd like to do is maybe focus initially on the radical nephrectomy, then we'll come back to the partial nephrectomy after that. Okay, so this slide shows a schematic. It's from a dissection guide by Westra, illustrated guide, showing a radical cystectomy specimen. And of course, it's very important to know your gross pathology for the pathologists to actually do the work themselves or carefully supervise residents or pathology assistants in this regard, because when one's looking at the slides, you really have to understand where the slides are coming from and what are the issues involved. So when one receives a specimen, of course, you want to measure it and weigh it. Another thing that's incredibly important about kidney tumors in nephrectomy specimens is really identifying the landmarks, especially the landmarks in the hilum. So one wants to identify the ureter, one wants to identify the renal vein as well as the renal artery and take the appropriate marginal sections from those before opening them longitudinally. The importance of opening them longitudinally, of course, is to identify if you can see any thrombus that's in the main renal vein or one of its major muscle-containing segmental branches, or if you actually see tumor that's breaching the epithelium of the renal calyces and pelvis. Because those are things that are related to prognosis. Now, the invasion into the renal pelvis is not specifically part of the TNM system, but certainly the involvement by tumor of the renal vein or its major branches is, and we'll come to that in a little while. The other thing, of course, is that one wants to paint the specimen appropriately. So if you have a specimen that doesn't have an obvious bulge, you might want to paint all of the fatty outer surface consisting of gerotous fascia. And if you have a bulge, like in the current example, sometimes what we do is just put paint over that particular area. And then after that's been done, of course, then we go on to bivalving the specimen. We're coming to that in a moment. So the next thing that we want to think about in terms of a checklist is sort of identifying some of the other sort of macroscopic observations that one wants to see. First of all, tumor site. This is an optional element, but I certainly try to include the location of the tumor in my reports. And, of course, the greatest dimension of the tumor is incredibly important. And we'll come to this when we come to the staging issue. The other two dimensions I generally do include, but they're considered optional with respect to the CAP protocol. The issue of focality is also important. While most renal tumors, these sporadic ones, are unifocal, sometimes one does run into multifocality and issues like that. And you sometimes come to the point where you might actually have two separate discrete tumors, even of different histological types, and one has to deal with that then with a couple of different reports or a couple of different checklists. Another important observation on the checklist is while you're doing your gross dissection, you want to make absolutely sure that you understand the gross extent of the tumor. So does it look like it's confined to the kidney, or is it involving either the perinephric tissues or the renal sinus? Has it gone beyond that sort of glistening fascial plane that's on the outer aspect of the radical nephrectomy specimen called Gerotis fascia? Is there gross evidence of extension into the major veins or the pelvis or cheliceo system? And of course, if there's involvement of the adrenal gland, is it involvement by a direct extension, which is now called the T4. It was T3 in the previous TNM, but now it's T4, and we'll come to that with the staging pictures. Or is it a non-contiguous involvement indicating metastatic disease? And of course, is there any involvement of other organs that might happen to be part of the specimen as well? So with respect to the blocking of the specimen, shown in this schematic also from the illustrated guide by Westra. This is just showing an approach to blocking of the specimen. And what I like to do, I like to try to sample these tumors. If they're small tumors, 2 or 3 centimeters, I put most of the tumor through, if not all of it. Tumors bigger than that, I certainly would sample them with at least 1 per centimeter or greater tumor diameter. And once again, I'm trying to focus as well on the issue of the staging. So I want to make sure that I have a section showing the interface, if it's a bulging tumor bulging out into the perinephric fat, showing that interface out here, and the renal sinus as well, because, and we'll come back to this, this is a very important point, that sampling of the renal sinus sometimes indicates the involvement of extrarenal fat. And in fact, this is probably the most common pathway of spread of renal cell carcinoma. And then one, of course, would also want to take appropriate sections of tumor in relationship to vascular structures, tumor in relationship to the adrenal gland, etc. And, of course, always take a section of the kidney away from the main tumor. And we'll come back to that point towards the end of the talk. Now, the practice of urology in kidney tumors has really moved in the last decade or more towards, doing nephron-sparing surgery. So, partial nephrectomy specimen, which is illustrated here in this very nice Mayo Clinic picture or schematic of a partial nephrectomy. These sort of specimens are very commonplace now. And this is just showing on the left-hand side a subcortical tumor that's bulging the cortex and capsule a little bit, and then showing the incision that the urologist has taken, actually exposing the collecting system over on this side. So sometimes these patients, of course, will have complications such as urinomas. So we commonly get these specimens, once again, trying to preserve as much nephron as possible. These are particularly important in the context of solitary kidneys and issues where patients have chronic renal disease, so you're looking for a nephron sparing. But as well, I think most smaller tumors and certainly tumors towards the poles of the kidneys are handled this way, irrespective of the clinical situation. So we end up with specimens that sometimes, or maybe even frequently, are less than perfect in terms of assessing them with respect to margins, etc. So what happens sometimes, we get a nice piece of intact perirenal fat. Sometimes it's disrupted. Sometimes we just get actually the capsule. And it's important in these situations to try to indicate what looks like, from our perspective at least, as our surgical margin of excision on the outer aspect. So there is this margin here then that would be considered, if there's no fat, it would be considered a capsular margin. If there's fat, it would be considered a perirenal fat margin. If, in fact, there is some gerota fascia there, then it would be considered a fascial margin. Then, of course, the very important parenchymal margin as well. I think most urologists try to get a reasonable margin if they can, but they do get into trouble sometimes, and there are times when they can only give us a couple of millimeters of clear margin. So looking at that margin very carefully is incredibly important. In this particular case, this is a very nice example of a clear cell renal carcinoma with that nice yellow cut aspect. So in these specimens, we want to make sure that we sample the tumor, obviously. We want to sample the outer aspect. We want to make sure that we've generously sampled that margin. Sometimes we get actually a separate specimen of fat, which may be separately labeled, and that, in fact, is the overlying fat associated with these cases. Now, I'd like to spend maybe about 10 to 15 minutes just talking about a little bit about the classification. So we're moving now from the specimen handling now into the sort of microscopic analysis of the kidney tumors. And there's been so much going on in the last few decades in renal cell carcinoma. In fact, of the areas of urological pathology, I think it's probably the one that's had the most dramatic change in terms of new types of tumors and things that have been described in recent years. So in the very old days, from 75 to the mid-90s, a lot of people were still talking about the very basic classification of renal cell carcinoma as being clear, granular, or spindle cell. And of course, you could have combinations of those as well. Well, the research that was done, especially in the late 80s and 90s, really started to find some very specific categories of renal cell carcinoma that had genetic correlation. So the clear cell of the old days has turned into the clear cell of the new days, but also as well within that category there's a chromophobe, a variant of renal cell carcinoma. The granular cell, or the tumors that are composed of these eosinophilic granular cells, some of those in fact fit into the clear cell category, and I'll show you an example in a moment. Some fit in chromophobe, some fit in the benign tumor called oncocytoma. And I should at this point maybe say that for the benign renal tumors such as oncocytoma or metanephric adenoma, one does not generally use the cancer checklist because the checklist is designed specifically for tumors that are considered malignant. Granular tumors also evolved into the papillary carcinoma category and the collecting duct category. And the spindle cell tumor, or the spindle cell carcinoma, which was described in the second series fascicle, really is not a specific subtype. It's sort of a pattern of dedifferentiation of any of the above categories. So in the late 90s, 2000, we have like the four major categories that have been described, shown in this picture with our clear cell carcinoma on the left-hand side at the top, the papillary carcinoma, right-hand side at the top, the chromophobe carcinoma, which evolved out of the work especially by the group at the University of Mainz in Germany, shown on the lower left, and the very ominous and aggressive collecting duct carcinoma with its characteristic fibrovascular stroma on the right-hand side. Now, mercifully, over that period of time, there was a lot of genetic work done as well, both with typical cytogenetics, classical cytogenetics, as well as molecular genetics, and there was very nice correlation between some genetic abnormalities and those categories of renal cell carcinoma. For instance, the conventional or the clear cell carcinoma shows a characteristic 3p deletion. The papillary carcinoma often shows trisomy of 7, 17, 16. The oncocytomas show a deletion of chromosome Y and 1. The chromophobes also show that, but show additional losses of chromosomes as well. And there's a little bit of variation in collecting duct and some of the other tumors that have been described in literature. But having said that, there is this sort of sense of correlation between what we were seeing morphologically as pathologists and what was happening from the point of view of the molecular and genetic pathology. So this brings us up to the 2002 when we had our WHO consensus conference, and at this conference we basically tried to define what are the definitions and criteria for the different categories of renal cell carcinoma, and also which other ones should be accepted within the classification system. So that meeting was actually in 2002, which is almost a decade ago now. The publication came out in 2004, and of course the field has moved on since. So my next slide here actually is showing where we are in 2011. So we have, in the light blue, we have the benign epithelial neoplasms, the sort of papillary adenoma, oncocytoma, and metanephric adenoma. Then we have our three relatively common types of renal cell carcinoma, the clear cell, papillary, and chromophobe. We have the collecting duct carcinoma, which is uncommon. We have the unclassified carcinoma. Then we have all these other types of rare carcinomas that have been described. Now, the ones with the asterisk, so the tubulocystic carcinoma and clear cell papillary and the carcinoma dialysis patients, were not well delineated in the WHO 2004, but those ones will, of course, be delineated in the next iteration of the Blue Book, which will probably happen within the next 3 or 4 years. Now, just from a practical point of view, though, when you look at a distribution of tumors that you might see in your routine practice, roughly 70% would be in the clear cell category, 15 papillary, about 5% chromophobe, and 5% interestingly oncocytoma. So together they are accounting for about 10% of the tumors, or 1 in 10 tumors that you're seeing. And collecting duct, less than 1%. And all those other miscellaneous, other rare ones, less than 1%. And unclassified carcinomas, there always has to be a category because there's so much diversity and so many things that have not been described yet in renal tumors. In various series might fit in sort of 3 to 6% of the tumors that one encounters. So it's important to have this category and not to try to force things into some of these other categories. Now, what I'd like to do now is just I'll just illustrate the common ones. We don't have time to really go into the details of all of the miscellaneous emerging tumors that have been described in recent years, but I just want to go through some of the common ones that you're going to be seeing. So this is a classical gross picture of a clear cell renal carcinoma with its variegated cut surface. And this one's interesting because it's showing really pretty good evidence that there is some extrarenal spread in the perirenal space here. And also as well, there's involvement of the renal vein in this particular area. So this is a very typical clear cell renal carcinoma. And the morphology is shown here with this kind of alveolar structure with these cells with abundant clear cytoplasm and atypical nuclei. Now, I want to point out, though, probably the most important aspect of this picture is not so much the fact that the tumor cells are clear, but there's this very delicate fibrovascular stroma with all these little capillaries in the background. And that's very important as a definitional point for calling something a clear cell or conventional renal carcinoma. And I say that because you get cases like this, and this is another example of a clear cell or conventional renal cell carcinoma. It's a little bit more uniform in terms of its cut surface. As you can see here, it's involving the central portion of the kidney, so you'd want to make absolutely sure you take lots of sections in this region here of the renal sinus to make sure there's no extrarenal spread in that particular location. But this is what it looked like under the microscope. So the cells really don't look that clear. They're very granular, but what is the same as the other picture of the typical clear cell carcinoma is that very delicate vascularity, that chicken wire type vascularity that's in the background. So really that's the definitional point. And it's been shown that these tumors that have this eosinophilia are very similar in behavior to the other clear cell renal cell carcinomas. They tend even to be a little bit more aggressive biologically, but they have the same molecular markers as the typical clear cell carcinoma. Another type of clear cell carcinoma that was recognized in the WHO and it's uncommon but not rare is the multiloculated cystic variant of clear cell renal cell carcinoma, which is shown here. And we have a gross picture on the left-hand side with this very nice multiloculated cyst, which of course would conjure up a differential diagnosis, which would include other things like cystic nephroma, or mixed epithelial stromal tumor, or cystic partially differentiated Wilms tumor, or even the recently described tubulocystic carcinoma would all be sort of differential diagnosis at a gross level. But microscopically, we see the cystic spaces lined by these cuboidal cells with some clarity, and as well we have these little nests of clear cells with very low-grade nuclei in the stroma. So that's sort of the multiloculated cystic variant. Papillary carcinoma is shown here. Once again, about 15% of the cases that we see. So this is actually a large aggressive papillary carcinoma. In this particular example, it has a dark tan-brown coloration. It's probably showing some evidence of extrarenal spread as well. And there's been a couple of different types that have been described by Ebley and Delahunt years ago. The papillary renal cell carcinoma type 1, which is composed of these smaller cuboidal cells that have more of a an amphiphilia or even basophilia on low power, and these tumors tend to have low-grade nuclei, 1 to 2 in the Furman system. And then this is the papillary renal cell carcinoma type 2, which is composed of the larger cells with more abundant granular eosinophilic cytoplasm with higher-grade nuclei, as one can see here. And in papillary carcinoma, as well, you not uncommonly see some ancillary features that are helpful diagnostically. So the collection of these foam cells is very common in papillary carcinoma. One may see little areas of psammoma bodies or psammoma-like bodies, and sometimes this incrustation of hemosiderin within the cytoplasm as well. Chromophobe renal carcinoma, about 5% of renal tumors is shown here. It can be a dark tan in coloration, or they can be lighter tan, as you can see here, or sometimes beige or even gray, very well circumscribed and often very solid in their appearance. And histologically, they have a very unique morphology in the sense that they have very hard cytoplasmic borders. And when you start looking at the individual cells, the cytoplasm is very spiculated. It doesn't have that clarity that you see typically with the clear cell renal cell carcinoma. And you can have either solid and glandular elements to this tumor as well. And this is just higher power view here showing some of the atypical nuclei that are very characteristic of chromophobe renal cell carcinoma. Often you can get this coilocytoid or this irregular chain, sometimes with binucleation, that is also a definitional feature of chromophobe renal cell carcinoma. Well, some chromophobes actually are more eosinophilic than they are sort of clear spiculated, and this is an example here. And you can see how a case like this would be difficult in the differential diagnosis with oncocytoma, but one sees scattered cells with a more typical conventional chromophobe appearance admixed with the ones that have more eosinophilic cytoplasm. Finally, we have of the traditionally described tumors, we have the collecting duct carcinoma, which is an aggressive neoplasm. In this particular example, showing a very nice epicenter in the central portion of the kidney around the renal medulla, as you can see here. It's a gray tumor with some areas of necrosis. And as I alluded to earlier, it has this very typical kind of appearance on low power with these tubules, sometimes with papillary, even solid structures, but you often get this very desmoplastic inflammatory stroma, which may include both lymphocytes and even neutrophils sometimes in the background with this sort of myxoid change. And this particular pattern even carries itself onto the metastasis as well, where you see this tubular or tubulopapillary morphology with this fibroinflammatory stroma. So that's just a little bit about some of the more common ones that one might see. As I said, we don't have time to get into the new and emerging subtypes, which is a talk unto itself. But coming back to our checklist, so this is our checklist that we have for tumor subtype or classification. So clear cell, multiloculated, clear cell, papillary, chromophobe, carcinoma of collecting duct. So we've covered those types. And in the WHO 2004, of course, we had renal medullary carcinoma, translocation carcinoma, carcinoma associated with neuroblastoma. The mucinous tubular spindle cell carcinoma was in there. Tubulocystic carcinoma was one that actually evolved after 2004, but we actually included in our checklist on the last go-around. Renal cell carcinoma, unclassified, a very important category, and even more importantly, to have another category for tumors that have been recognized since the WHO classification, which are evolving into entities as we speak. Now, the other important feature with respect to the histological subtype is the issue of sarcomatoid features. And it's important to indicate whether they're present or absent, and to specify a percentage of the sarcomatoid element as well. With respect to the prognosis for renal cell carcinoma by subtype, oncocytoma, which is shown on the left-hand side, is a benign disease. So the chromophobe behaves better than the papillary, which behaves better than the clear cell, which behaves better than the unclassified ones, which tend to be a heterogeneous group of tumors, often with some very high-grade tumors admixed in this category over here. And another work from Holger Mock in Europe showing once again chromophobe behaving better than papillary and better than clear cell. So there is a correlation between the histological classification and the overall outcome for renal cell carcinoma. Now, sarcomatoid carcinoma, as I said, is is a common pathway of dedifferentiation that can occur in clear cell, papillary, chromophobe collecting duct, and even more recently, there's been a number of descriptions of mucinous, tubular, and spindle cell carcinoma, which tends to be a benign tumor undergoing spindle cell transformation or sarcomatoid transformation and having a very bad outcome. So it's not recognized as a specific type onto itself, but as a dedifferentiation pathway. And in this particular example, this is an example actually of a collecting duct carcinoma. You can see the remnants of the collecting duct carcinoma on the lower right-hand side, and on the left-hand side we see this aggressive spindle cell neoplasm conferring the descriptor of sarcomatoid on the renal cell carcinoma. So the sarcomatoid histology has an adverse outcome, and there's a number of series now talking about the sarcomatoid morphology, and also the quantitation of the sarcomatoid morphology has a effect on prognosis. And on the left-hand side, this beautiful gross picture from David Grignon showing this. This is a clear cell carcinoma showing the more typical clear cell areas up here, but this white-gray part is actually the sarcomatoid element on the left-hand side. Now, so that's sort of classification and sarcomatoid subtype, sarcomatoid change. The other issue with respect to tumors microscopically is the issue of tumor necrosis. Now, tumor necrosis from the CAP checklist perspective is not included as a mandatory element. I do include necrosis in my reports. It's used by a number of investigators and people that are putting together nomograms for renal cell carcinoma. There's certainly some good evidence suggesting that necrosis is important and may in fact be a mandatory element at some point in time. And this is just an example here of a really extensively necrotic renal cell carcinoma on the left-hand side, shown histologically on the right-hand side with the remnants of the clear cell carcinoma on the bottom. So I do include that in my reports for renal cell carcinoma. Now let's move on to some other histological features. So histological grade, it's important. We generally follow what's referred to as the Furman nuclear grading system, which is shown on the checklist on this particular slide. As well, when we're looking at the slides, we're always constantly, when reviewing our slides, trying to look at the issue of these evidence of microscopic tumor extension as well in the various different spaces, depending on the blocks that we've sampled, of course. So we'll come back to this. We'll focus more on this when we talk about the staging, but let's focus now on the grading. So the Furman system's been around a long time, almost 30 years. And the Furman system in its original description had a number of criteria that related to the size of the nuclei, the shape of the nuclei, the chromatin texture, and the nucleoli. So we have the grade 1, round, dense, absent nuclei, grade 2, bigger, round, open, small nucleoli, grade 3, even bigger cell size on average, round to oval, open, with large nucleoli that are visible with a 10x objective. And then the grade 4, which tend to be pleomorphic ones that could be even identified on very low power on 4x or scanning objectives. But what's happened really over the years, having looked at the literature and talked to a lot of people about it, is that people generally are not using these criteria so much. It's really the nucleolar criteria that people tend to focus on, with, in grade 1 being absent, grade 2 small and only visible on higher magnifications, grade 3 being present with 10x objective, and then the macronucleoli, the pleomorphic cells that could be identified on scanning magnification. So that's sort of how people generally are using the classification system these days. So nice example here on the left-hand side, upper, that would be a grade 1. We virtually hardly ever see these. Occasionally, the multiloculated cystic clear cells will be this grade, and the solid ones on very rare occasion. Furman nuclear grade 2 on the upper right, where you can see on high power, you can see these relatively small nucleoli, but they're certainly visible as you go up in magnification. Grade 3 on the lower left, and of course the big, large pleomorphic cells, even if they're very focally present in a tumor, would put it up to a Furman nuclear grade 4. And this is from the original Furman paper, showing the relationship between the nuclear grade and survival on the x-axis. There's been more recent studies as well. This work that Dave Grignon did actually quite a while ago now, but Dave found that, in fact, it was very rare to find firm nuclear grade 1, so he actually lumped his 1s and 2s together. But you do get a nice separation, 1 and 2 versus 3 and 4 in terms of survival in this particular analysis, and also showing, once again, the 1, 2, 3, 4 types of morphology on the left-hand side. Like in a lot of areas of surgical pathology and oncological pathology, there's problems with reproducibility, and these are just showing the kappa statistics from a number of series that have been published, indicating only fair agreement at the very best, and in many cases relatively poor agreement. One also has to deal with the issue of grade heterogeneity, and you can see here is an interesting slide because on the left-hand side shows a relatively low grade clear cell, probably nuclear grade 2, but on the right-hand side you have these large pleomorphic rhabdoid-looking cells, and when you see that, of course, that would be nuclear grade 4. So you grade by the worst area, so this case would be graded as Furman nuclear grade 4. Now let's spend some time on staging. We have to give credit to Dr. Robson, Professor Robson of the University of Toronto, who really was one of the ones that really started the whole staging schemes for kidney cancer, publishing some great work back in the 60s and 70s, and he's really known in the urological community for that huge contribution, showing this kind of more primitive approach to staging, for instance, in the TNM, but also showing very strong correlation with outcomes. So I just wanted to put that in there for historical significance and to show a little bit of Canadiana, if you will. But let's now talk about the TNM system, the 7th edition TNM system, and this is what the checklist looks like. So I won't read all those elements that you see below because we're going to go through them in a systematic fashion, slide by slide. But basically, this is the TNM system that came out in 2009, so it's the 7th edition, and it's up to date. But I think I will point out one thing is a lot of the criteria related to PT1 and 2 relate to the tumor size. And the backup literature for that is actually very strong. In this particular paper here, just showing this stratification of survival by size of renal cell carcinoma, 1 to 3, 4 to 6, 7 to 9, greater than 10. So this is the sort of information that the AJCC, UICC task forces will look at, prior to making any sort of recommendations regarding changes in the TNM system. So if we go through the system now, the 2009 system, the T1 tumors are less than 7 centimeters. So the ones that are less than or equal to 4 would be classified as T1A, and those that are 4.1 to 7 centimeters would be classified as T1B. So once again, confined to the kidney with no evidence of perirenal or renal sinus invasion and less than 7 centimeters. Another example there. And when you get to tumors that are more than 7 centimeters, then and actually from 7 up to, there's no upper limit on it, but from 7 to 10 would be considered as a T2A and T2B greater than 10. Now we'll come back to this point in a moment when I talk about the renal sinus, but there is some suggestion perhaps that these large tumors that are currently called PT2s might not in fact be PT2s if you took enough sections of the renal sinus. Now, when we come to the issue of local invasion, so PT3, sort of in the lower half of this diagram here, if we could focus on over here. So PT3 is when you have either invasion into the perirenal fat, as you can see here, or into the renal sinus fat that you can see here. So those would be both considered as PT3A. PT4 is when you have actual direct invasion into the adrenal gland or into other structures, or it's going out beyond Gerotis fascia, which is over here. And on the right-hand side, we see this very large tumor, very nice insert here showing clear-cut invasion into the fatty tissue. So that's what we like to look for. And if you have sort of a pushing tumor border with a nice fibroinflammatory or fibrous pseudocapsule, that does not constitute invasion. So what one wants to see is tumor cells kind of admixed or opposing adipocytes directly. Now this brings us to the renal sinus. This is a very important structure and was probably recognized in the beginning by the group that did lots of work on Wilms tumor as an incredibly important pathway of spread of Wilms tumor, but it was really only picked up in the surgical, the more adult renal tumor literature about a decade ago by authors like Steve Bonsip, who at the time was at the University of Indiana. And it's important to recognize that this is the section, transverse section across the kidney. We have our capsule. Everybody knows there's a renal capsule out here, and this tissue around out here would be the perirenal fat. But then the capsule actually stops there. So we have actually columns of Bertan that would be in direct continuity with the fat and very close to some of these sinusoidal blood vessels that are down in this region here of the hilum. So this is an incredibly important pathway of spread, and this really is the sort of place that one wants to sample extensively if you have a tumor that's kind of going into this area. Even if it looks like it's smooth and regular, it's important to get sections in there just to confirm that in fact there's not true invasion out into the renal fat. These are some very lovely pictures of Steve Bonsip's work, taken from the American Journal of Surgical Pathology back in 1999 in color, showing the tumor actually getting out into the renal sinus fat over here. So a very important area to concentrate on. Here's an example here. These are two tumors that have a central or hilar location. This one here on the left-hand side did not show any evidence of renal sinus involvement, where this one over here did actually show some infiltration into the renal sinus. There's been a number of studies now done as well, and in fact, this one study done by Thompson et al. And published in the journal Urology in 2005 suggests that renal sinus invasion may be even more important than perinephric fat invasion in terms of determining prognosis. So it's something that as pathologists we really got to talk to. If we're doing the growth ourselves, we really got to focus on. We've got to make sure that we've educated our residents and pathology assistants in taking the appropriate sections from the renal sinus. And this is the point I was alluding to earlier. In some work that Steve Bonsip did and published in the Journal of Urology, he's suggesting that if you take a minimum of 5 sections in the tumor sinus interface, that in fact you have a very high prevalence of involvement of the renal sinus, to such an extent that when you get tumors that are greater than 7 centimeters in his series, it's almost 90%. So in fact, this one should not be classified then as a PT2B, but in fact it would be a PT3A. So I think what's going to happen is that over the next few years there'll be more literature coming out, and there may be some additional modifications in the TNM in the next iteration of the AJCC system. Now, continuing on, so another way that you can get to PT3A is if you have tumor that's invading into the renal vein or its segmental muscle-containing branches, which is shown in this particular slide here. So renal vein invasion would be PT3A as well. PT3B is when you have a tumor that's actually getting out into the IVC but below the diaphragm, and PT3C would be above the diaphragm. Sometimes, of course, this is very difficult for us to judge as pathologists, and it comes down to sometimes with a correlation with imaging and discussion with the urologist as to the appropriate P classification in these cases. Now, one of the big changes in the AJCC system was relationship to the adrenal gland involvement. So in the old system, in 2002, TNM number 6, we can see that when you have direct invasion into the adrenal gland as shown here, there's a bit of the adrenal gland there with the tumor getting into it, it would be classified as a PT3A. But if you had a discrete nodule involving the adrenal gland here, then it would be a PT2M plus or M1 there. PT2 here, and then this is just M positive disease. So the literature that evolved in the interim years between the 6th and 7th edition suggested that, in fact, the situation was much worse than was being implied by a PT3 category. So here we go once again with the tumor that's directly invading into the adrenal gland, shown here and here on a little bit higher power and here microscopically. So this is now categorized as PT4 disease. And of course, this situation here where we have the discrete discontinuous nodule continues to be classified as a PT2M1 disease. So that's a significant difference, that PT3 to PT4 classification. As well, if you have a tumor that's very large and aggressive and invading out beyond that sort of fascial plane, gyrotous fascia, that would also be classified as PT4 disease. What's happened over the years is that there is sort of a stage migration to lower stage tumors. Of course, that's just because I think the better imaging and more awareness of tumors, lots of incidentalomas sort of coming up during ultrasound examinations as well. But there's definitely a trend towards lower stage with more advanced years. As well, I think there's very good evidence showing very strong correlation between T category in AJCC and outcome. So it's a very important prognostic factor and one that the urologists use and expect us to sort of provide on our reports. This is just showing, once again, very strong survival differences between the various stages or stage groupings and outcome for either 2, 5, or 10 year survival. So that brings us now to the checklist. We're getting towards the end of the checklist. And of course, one thing that one always wants to make a comment on is the margin status. We talked about the margins when we were looking at the gross description or the gross assessment of the nephrectomy specimens, both the partial and the radical nephrectomy. So the margins that one has, basically, if you're dealing with a parenchymal, if you're dealing with a partial nephrectomy, you usually have a renal parenchymal margin, and of course you may have a renal capsular margin if there's no fat, or a perinephric fat margin. Whereas in the radical nephrectomy, you tend to have that fascial or that Gerotis fascia margin as well, in addition to renal vein margins and ureteric margins. So those are the sort of things that we want to make sure that we comment on and we fill out this checklist. And as you can see, these are all mandatory fields in the checklist that would be difficult to sort of get past unless one had some response to. Another feature that is evolving as perhaps a important prognostic factor, but hasn't really been recognized yet in T&M, but certainly something I do include in my reports, is whether or not you have lymph vascular space involvement. So this is really the vessels that are exclusive of the renal vein and its sort of major segmental branches. It's sort of the other vessels, most of which don't have any sort of muscle associated with them as well. So I do tend to make a documentation whether or not that sort of observation is identified. And here's an example here of angiolymphatic invasion showing a significant positivity with a clear cell renal cell carcinoma, showing some tumor thrombus associated with it as well. Lymph nodes, we generally don't get lymph nodes are generally not included with partials unless they're sent as separate samples. With radicals, there are generally not that many lymph nodes for the most part. If most renal cell carcinomas we find, even if we search hard, we're hard pressed to come up with 1 or 2 lymph nodes. Sometimes you might see a little cluster of small lymph nodes in and around the hilar vessels. We sometimes get criticized by our clinical colleagues about this, but certainly in my experience, we don't generally get a lot of lymph nodes with the routine radical nephrectomy specimens. However, nowadays I think there is more of an emphasis on lymph nodes in renal cancer and also in bladder cancer. So sometimes what we're seeing is more separate samples submitted as well, or more extended dissections of the hilar region, in which case one would expect to find some lymph nodes. And once again, just emphasizing that important category that's now been added thanks to the Canadian input, no nodes submitted or found. So that would pertain to a case where basically nothing was found in the majority of the nephrectomy specimens that we're seeing. Now, another important point that I want to emphasize, and this is something that really there was a very good, solid discussion between the Renal Path Society and the College of American Pathology of the importance of taking sections away from the tumor and identifying whether or not there's any other intercurrent histological disease. So here we have an example of nodular glomerular sclerosis of diabetes that's found in the kidney away from the tumor, and is a very nice review that I draw your attention to by Steve Bonsab in Advances in Anatomical Pathology last year. I think it was July last year. He goes through a very systematic approach to all the different other types of lesions that one could see in the adjacent kidney. And in fact, sometimes the adjacent medical disease that might not be recognized by the clinicians may be more important in determining prognosis than the tumor itself. So it's very important to recognize that, and that's why this section is in there, and this is a mandatory section of pathological findings in non-neoplastic kidney. If there's insufficient tissue, for instance, if you just have a partial nephrectomy with a very thin rim of adjacent kidney, then one wouldn't be able to comment on it. But in other situations, one will want to identify, is there no significant pathological alterations, or is there some glomerular, tubular, interstitial, or vascular disease? We could have went on forever in subcategorizing this in a checklist format, but we really just wanted to draw people's attention to the importance of looking at the non-neoplastic kidney away from the tumor. And of course, as well, we also included this following category, which is optional just for other lesions, other sort of cysts, and perhaps other little tubular or papillary adenomas that might be present in the specimen as well. Now, what about new prognostic factors? Well, nothing has really reached prime time with respect to prognosis prediction in renal cell carcinoma as of yet. Certainly nothing has got to the level of HER2 or KRAS or EGFR in non-small cell lung cancer, but there's a lot of stuff being done, of course, in terms of FISH, molecular genetics, CGH, etc. A lot of stuff is happening, and you might see some biomarkers evolving over the next few years. Now, this is coming back to that point I was alluding to earlier, and there are a number of nomograms that are out there for predicting a recurrence in patients with renal cell carcinoma. This particular one is designed for clear cell renal carcinoma, and it's based on points. This is very similar to the nomograms that one uses for radical prostatectomies as well, where you put in a size, a PT category, a grade using Furman, whether or not there's presence or absence of necrosis, and hence the importance of that particular observation, vascular invasion, and how the patient presented, whether it was sort of a localized or a systemic presentation. You come up with a total number of points, and you could have a 5-year prediction of probability of being recurrence-free. So there are some urologists, oncologists, and cancer programs that would be using these sort of nomograms, which is really dependent on the sort of information that we're providing in a standardized fashion in our surgical path reports for cancer resections. So I think I'm going to finish up here, and I just wanted to draw your attention to this lovely book that was published by Atul Gawande. He's a surgeon, general and endocrine surgeon at the Brigham Hospital, Harvard Medical School, Boston. And it's a very nice book talking about how the lowly checklist has improved complex processes in various different parts of society, including the aviation industry, the sort of, construction industry, other sort of complex constructs, and of course focusing on medicine and in particular on the surgery checklist, which I think most of us will probably be aware of, that there is a surgery safety checklist that has now been endorsed by the World Health Organization and by Canadian groups as well, and it's providing, even though it's a very simple structure, it's actually been shown to actually improve quality and patient safety on a go-forward basis. So it's a nice little read for people that are interested in this sort of thing. I think, it's an innovation that's very simple, and I think simple innovations are often the ones that are most important in terms of moving things forward. And I'll just end on a final picture, and this is for Sarah. You can see the electron microscope and the caption at the bottom. I think I see my paycheck. Thank you very much.
Thanks, John.
Thanks, John. That was really excellent. And I know in your bio you said you're a strong advocate for population-level standardized synoptic reporting, but I think you need to add you're also an advocate for pathologist-level standardized synoptic reporting. You do listen to our feedback, and I think we cannot underestimate the influence we can on improving the CAP checklists. I do encourage everyone to submit questions via the chat feature. We haven't got any questions that have come in. I've got a couple of questions, John. The first one is to do with the gyrardus fascia. Sometimes I really find it difficult, even reading in the anatomy books, just exactly what is gyrardus fascia. How do you recognize it grossly? And do you see the ability to actually grade nephrectomy specimens similar to what we do with rectal cancers, the TME or the total mesorectal excision, where we can actually say whether it's complete or partial or incomplete, because that's some difficulty we find when we gross these specimens as to exactly what is gyrardus fascia and how do we actually know it's on the specimen.
Okay, very, very good point, Dimo. The gyrardus fascia is that kind of, when you're looking at a radical, and it's that very kind of thin, shiny, membranous structure that sort of overlies the surface of the fat. So it's a very delicate sort of structure. Now, there is some controversy as to some of the terminology. Now, some people refer to the whole envelope around the whole kidney, excluding, of course, the medial aspect, as being Gerotis fascia. But I think the more proper terminology is that that glistening membrane that's on the anterior aspect of the radical nephrectomy specimen is Gerotis fascia, and the corresponding one on the posterior aspect is called the fascia of Zuckerkandl. Now, so within those fascial, the perinephric space is defined as what's going on in between the renal capsule and the fascia, either anterior or posterior. So that's called the perirenal space. Now, if you're anterior to the Gerotis fascia, then you're in the pararenal space. So P-A-R-A, the anterior pararenal space, which of course is where for instance, the descending colon and the pancreas sits as well. So that's pararenal. So the perirenal is within that fascia, and the perirenal is outside the fascia. And then posteriorly, if you're outside of Zuckerkandl's fascia, then you're into the sort of posterior pararenal space. So, but you're right, it is difficult sometimes to know exactly what it is. It's that delicate sort of shiny membrane. And with respect to grading with TME specimens, I mean, I do tend to comment if there is some disruption, specifically overlying the area of concern. I think it's a big specimen, and you do see sometimes little breaks here and there. So, and I don't think there's a lot of data suggesting that is necessarily important. It may be in some cases of more advanced stage disease where we're trying to get a complete cancer resection specimen, but there's really not a huge amount of data that similar to what we'd have for TME specimens for rectal cancer.
Okay. I've got a few more questions, but we've actually had a question submitted, and it's from Gillian Bethune. She's from Queen Elizabeth Health Sciences here in Halifax. How do you handle tumor nodules in perinephric fat that are not continuous with the main tumor mass and not in the adrenal gland?
Well, if it was a discrete nodule that was, and we're talking in the context, I assume, that there is an actual tumor in the kidney as well, and that there's then another one that's sort of outside in the fat. I would consider that as metastatic disease, M1 disease.
Okay. I'll go to one of my questions, John. I saw that they're actually contemplating of expanding the PT classifications where they actually say if there's involvement of the inferior vena cava, at least gross involvement of the inferior vena cava. My question is, how would you actually even get a surgical specimen? I would think that if the inferior vena cava was involved, no surgeon would really take that out. Is that more of a clinical, a CT, rather than a PT sort of addition?
Well, I guess there's a couple situations. Sometimes you actually get a resection that includes, a whole portion of the renal vein right down to the junction with the IVC, and then you may see tumor thrombus that's extending out beyond that sort of. So you can identify that it's certainly more than PT3A in that situation. It might be very difficult to identify whether or not it's gone beyond the diaphragm or not, and that's why it's important to talk to the radiologist and the clinician about that as well. But sometimes as well, you actually have tumor that's actually going out and invading the wall of the renal vein itself, the actual muscular wall, or the muscular wall of the IVC, and then you might have to involve a much more complex surgery with involving a vascular surgeon as well. But those are rare situations. For the most part, I think we can see invasion into the renal vein, and we might be able to identify that it's beyond that if there's a tumor thrombus that's sort of hanging out. But we really can't be too precise sometimes unless we get one of these very unusual cases. Thanks.
We've got a question from Rock Robertson, and Rock says, John, do you use immunostains, that is D240, to identify lymphatic invasion and renal cell carcinoma?
I haven't been using that on a routine basis. we tried it on some selected cases where there's where it's quite equivocal, and in my experience, it hasn't been that useful. So we're not routinely using it. We're sort of going more by traditional H&E criteria, of an expansile lesion within a preformed space, thrombus, that sort of thing. But I mean, occasionally it helps, but we certainly don't use it on a regular basis.
We've got a second question from Gillian Bethune from Halifax, I believe. And how do you handle tumors with mixed grades? So 95% grade 2 out of 4 and 5% grade 3 out of 4.
We grade by the worst area. So it's very much like bladder cancer. So whatever is the worst area, even if it's a small proportion, one would assign the grade based on the 5% of the higher grade pattern.
Okay. A question from Jennifer Ramsey, I believe from Hamilton. Do you use any special stains, for example, elastic for identification of sinus and the capsule?
No, I haven't been routinely doing that. Certainly nothing like we would use, for instance, in lung cancer to identify sort of the pleural membrane. We've not been doing that on a regular basis at all.
And actually, there's a second part to Jennifer's question, which is actually one of my questions was, should non-tumorous kidney be submitted as a medical renal biopsy protocol? So, freeze some, put some in for electron microscopy, etc.
Not unless, not in a routine situation where one is just, getting a nephrectomy for a tumor. I think it's sort of a routine sample for H&E is fine. I think if there's some indication, though, on the requisition, or if you get, some indication from the clinician that there is sort of a associated medical condition or potential associated medical condition, and we have had cases here exactly like that, we make sure that we take the appropriate samples for ancillary studies with snap freezing, etc. So I don't think so on a regular basis. That might get to be a little bit much, but certainly in selected cases, if there's some indication either clinically or pathologically that draws your attention to something.
Okay. And we have a question from Dr. Joseph Wasilewski. I don't know where he's located. Query staging multifocal renal cell carcinomas in partial and radical nephrectomies. And can you comment on staging of multifocal renal cell carcinomas in partial and radical nephrectomies? I think that's
okay. Yeah, thanks, Joe. Joe's in Thunder Bay. The issue of multifocality is important. And as I said, there are some tumors where you do have, multiple foci of the disease, which may in fact be separate tumors altogether, or may in fact be just multiple similar histologies. The issue there is that you sort of grade by, or sort of you stage by whatever is the most advanced stage. So if you had discrete tumors that are like miles apart, then of course one wouldn't want to be adding them together. But if you had a mass that was sort of like more admixed or sort of juxtaposed to one another, I would probably, if it was the same histology, sort of include the greatest diameter of both of the nodules if they're sort of abutting against each other or sort of intermixed at the interface. But if they're far away, I think you just take the largest one as the one that was the driving stage. Or in fact, if the smaller one was a smaller tumor, but in fact was invading out into fat, then of course the default would be a PT3A. So one would take always the most advanced stage in a separate nodule as being sort of the stage for treatment and surveillance purposes.
Okay. I guess the spin-off of that, John, is have you ever encountered two synchronous primaries in the kidney, but different types? So one may be, for example, a clear renal cell carcinoma, another a papillary, and how would you handle that scenario?
Yeah, absolutely. That does happen. It's not that common, but that you have disparate histologies, but it certainly occurs. What I do is I tend to take what I consider the most significant one in size, and then I would complete a checklist for that related to CAP. And then I think you have the option at that point of actually doing a separate checklist for the second one, or actually using your comment field to sort of generate a synoptic-like report, if you will, in a comment field for the one that would be less significant. So you could either do it sort of with two formal synoptics, or do it with sort of a more flexible way of just including the information in a comment saying that there's a second tumor. It's a smaller tumor. It has certain characteristics that you might list in a synoptic-like fashion. So there's different ways of handling that, but I think it's important to try to identify if they're disparate histologies to make sure that the urologists, oncologists understand that. And of course, in your diagnostic field, you'd have two separate lines, right? One for each of the tumors. And really, depending on your system, the whole issue of the multifocality. I mean, that's something that's sort of across many different checklists too, how to handle sort of the multifocal tumors. And I think we'll be gradually getting more and more guidance from the college and from others on how to handle that situation.
We have an anonymous question from the London Health Sciences Centre. What is the role of immunohistochemistry in the classification of renal cell carcinoma?
Ooh, that's a sweeping question. But it does. I draw your attention to the paper in the January issue of Archives by Trun and Steve Chen from Methodist in the U.S. It's a review article on the immunohistochemistry in the diagnosis of renal neoplasms. It's really quite good. So, that's a hugely complex question. I mean, having said that, I think what I generally do, I think in the situation where you're dealing with metastatic disease like in a needle biopsy, that's where, it's very important to know that, for instance, markers such as RCC and CD10 are pretty reasonable markers for clear cell renal cell carcinoma, and CK7 and racemase are good for, papillary carcinoma. It's important to understand that when you get into tumors like oncocytoma and chromophobe, they tend to be vimentin negative, whereas vimentin's positive in the papillary and the clear cell carcinomas, and that the differential between chromophobe and oncocytoma is complex, and the markers are sometimes helpful but not always. So if you have a more CK7 expression, that would be more in favor of eosinophilic chromophobe, or if you just have a few spotty cells positive, that's more the features one sees with oncocytoma. So it is a complicated question. It really depends on what scenario you're dealing with, But I have to say that I think, in probably 19 out of 20 cases, you can make a pretty good diagnosis on the basis of H&E.
Okay. A question from Dr. Mark Rickenberg. What samples should be submitted if you suspect a rare variant defined by cytogenetic features, for example, translocational subtype? Right.
A lot of the stuff now can be done on paraffin, mercifully. So, if you do have something that you recognize, as like a young patient, teens or young adult, and you're thinking about translocation carcinoma, or if it's a post-neuroblastoma patient that has a tumor or some very unusual hereditary situation, it wouldn't hurt to snap freeze a little bit of that tissue for further studies. I think a lot of the stuff can be done, using molecular genetic technologies and by immunohistochemical markers as well, such as TFE3 for the translocation carcinomas. But it's certainly wise if you do think it's an unusual situation like that to do at the very least snap freeze some. But I think a lot of the PCR tests that can be done now can be done reasonably well on paraffin embedded tissue, and of course the immunomarkers work well as well, as long as the fixation is good with the proper fixative neutral buffer formalin, etc. So it's wise to at least think about that. And I think in that situation I would definitely try to snap freeze a portion of it. But beyond that, I don't think you have to be worrying about submitting stuff fresh for cell culture and things like that, unless you're in a research environment.
John, have they done a correlation between the sort of H&E classification of tumors with the translocational? Is there a good correlation, I guess, just using light microscopy and special stains versus molecular? And what do you think the role is of molecular testing in renal cell malignancies?
Well, I think the translocation carcinomas are, first of all, they're rare. They tend to occur in teenagers and young adults mostly, although they can rarely occur in the older age ranges. And they're sort of, there's a number of H&E clues. For instance, if you have a tumor that has a papillary architecture but a lot of clear cell change in it, that might point you towards in the direction of a translocation carcinoma. They also can tend to have psammoma bodies. They also tend to be, if you do keratin stains, they're often very keratin poor in their expression, and they may show positivity for melanoma markers, interestingly, so causing some confusion, sometimes a differential diagnosis. But most of those tumors can then be clarified using the TFE3 or TFE-B stains and appropriate PCR reactions that can be done on paraffin. So I think that, I think the molecular stuff is certainly fine-tuning. As I said before, in the beginning, there's reasonable correlation between molecular stuff that's been done in our current classification, but on a go-forward basis, I think that some of these newer entities, there are interesting molecular aspects that are being uncovered at all times.
Another question from Mark Rickenberg is there an easy way to orient the kidney as to upper and lower poles if there's no adrenal included and the surgeon has not oriented the specimen?
Well, I mean, once you get past the adrenal gland, I mean, if you identify the renal pelvis and the sort of direction of the ureter, that you could sort of, that helps with the up and down orientation. But sometimes it gets very confusing, and you sort of have to, give the urologist a call, get him to come down to the gross area to sort of give you some orientation. But I think most of the time one can, with adrenal and sort of the direction of the of the ureter and the shape of the renal pelvis, you can sort of figure it out.
Well, there's no more questions that are coming in. I think we've had a lot of questions. I think they've been very excellent questions. It's been an excellent presentation. John, thank you very, very much. And on behalf of everyone, I do want to thank you, John. So I'm just going to have my closing remarks. And on behalf of Cancer Care Ontario, the Partnership and the Canadian Association of Pathologists, I'd like to thank Dr. John Srigley, I think, for a truly comprehensive, informative, and very clear presentation. This was our 7th and final session in the second series of the CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure these sessions are informative and relevant to your practice. Currently in the process of planning future sessions, please indicate your feedback and suggestions as part of your completed online evaluations. Once the WebEx recording of this presentation becomes available, it will be made available for wide distribution via links posted by Cancer Care Ontario, the Partnership, and Canadian Association of Pathologists. Access to this recording will be available for your review at your convenience and is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits, and for once you receive those, attending or reviewing the recorded sessions, one must complete an evaluation form for each session accessed or viewed in its entirety. The link to the web-based survey has been included in the session notices distributed prior to each session. If you're not able to access the web-based evaluation, please contact Sarah Langshire, and her email, I think, has been included in the emails forwarded, but it is sarah.langshire@cancercare.on.ca. This information, as I said, was included in your notice distributed earlier. CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Also note that the information for each education session is distributed 10 days prior to the session date and are distributed via CPAC, the OAP, and the CAP ACP distribution list and websites. Please check these sources for the session information. Thank you very much for your attendance, and once again, John, thank you very much.